Just close that. Yep. Okay, hi everyone. So my name is Kenny. I'll be one of the tutors throughout the course these 2 years. Hopefully I'll get to meet every one of you and get to know all of you quite well throughout the course. I'll be going through with you all a very important and fundamental modality of cardiac investigation, which is the electrocardiogram or ECG. And I hope that every one of you has gone through and listened to Dr. Eshu's lecture, the Essentials Cardiac Electrophysiology lecture, because this tutorial will be an extension to that. So I'll go through some of the learning objectives that we'll go through today. So we'll be discerning the key features of a normal electrocardiogram. We'll also recognize important elements of certain abnormal ECGs, and then apply a systematic approach to the evaluation of an ECG as well. And then some specific things we'll talk about is ECG electrode placement, defining the key features of an ECG, and then we'll go through a systematic approach to basic ECG interpretation, and I'll go through some examples as well, and then how I would go through the systematic approach to those ECG interpretations. So one thing that I saw from Dr. Eshu's talk is she did admit a bit about ECG electrode placement. This is very important in order to ensure you get an accurate ECG interpretation. This might be revision for some of you who might have already had some ECG exposure experience. So ECG can be split into two different leads. So you have limb leads, and then you have the chest or precordial leads. For the limb leads, you would be putting 4 electrodes for a resting ECG at the right and left wrist, and the right and left ankles. So the right arm in the right wrist and the left arm in the left wrist, right leg in the left right leg, and left leg in the left ankle. If, however, you are performing a stress test, then these limb leads would then have to be closer to the torso in order to minimize any noise or artifact. And to do that, you would place the right arm electrode just below the right clavicle, and then you would put the left arm electrode just below the left clavicle, and the right leg electrode right below the right lower edge of the right rib cage, and the left leg just to the lower edge of the left rib cage. For your chest and precordial leads, V1 electrode is placed at the 4th intercostal space just to the right of the sternum. The V2 electrode is placed in the 4th intercostal space just to the left of the sternum. The next electrode we place is usually V4, and that goes in the 5th intercostal space at the mid-clavicular line. And then we then go back to V3 because we put that electrode in the midway point between V2 and V4. V5 electrode is placed in the 5th intercostal space at the anterior axillary line. And then last of all, V6 is placed at the 5th intercostal space at the mid-axillary line. So when you've attached all the electrodes on, you can get 2 different types of ECG. The first one is a rhythm strip. The rhythm strip is used just primarily to interpret the heart rhythm. So for example, if they're in a sinus rhythm, so the impulse is coming from the sinus node, or if you're in atrial fibrillation, you can tell what the rhythm is from the rhythm strip. The more detailed strip is the 12-lead ECG, and this gives you a very detailed identification and as well as localization of the electrical activity happening around the heart, and then it can be used it can be used to ensure that you can localize certain abnormalities as well. And then we'll go on to define some of the key ECG terms. So these are some things I'm going to talk about next. So I'll start off with the P wave. So the P wave is the first positive deflection on the ECG, as shown below here. It represents atrial contraction or depolarization, and it's most clearly seen in lead 2 on a 12-lead ECG. And it's used to identify the cardiac rhythm, as you can see the P wave most easily. And the normal duration of the P wave is usually about 80 milliseconds. For the QRS complex, this is a combination of the Q, R, and S waves. It represents electrical impulse traveling through the ventricles, so it represents ventricular depolarization. And the normal duration of the QRS complex is less than 120 milliseconds, or 3 small boxes. So the last of the waves is the T wave, and it's a wave that comes after the QRS complex. It begins at the first deflection of the ST segment and finishes at the return to baseline of the isoelectric line. And this represents ventricular repolarization. So now we'll go through some intervals that we measure and identify. So the first interval is the PR interval, and this is the interval measured from the beginning of the P wave to the beginning of the QRS complex. It represents the time taken for the excitation to spread from the atrium to the ventricular muscle. And normal duration is between 120 and 200 milliseconds, so around 3 to 5 small boxes. And if you can have some abnormalities with this, so you can have a shortened PR interval, and then this may indicate that the patient with a possible delta wave, it might signify that they have a Wolff-Parkinson-White syndrome. And if you have a prolonged PR interval, it can represent that the patient has some sort of heart block or AV block, where there's a delay through the conduction of the AV node. So next I'll talk about the ST segment. This is a section of the ECG between the J point and then the beginning of the T wave. So you can see here, this is the J point, also known as represents the junction point, and it marks the end of the QRS complex. And it's very important to identify this, so then you can see where you would then measure the ST changes. And the ST segment is very useful and important in identifying any occurrence of acute myocardial infarction or any ischemia. So you can see here in this example, this is an example of ST depression. So you can see this is the isoelectric line here where our mouse is, and then this ST segment is depressed. So it's underneath the isoelectric line, and this can indicate myocardial ischemia. And then in this example on the right here is an example of ST elevation. As you can see, this ST segment is elevated above the isoelectric line, and this represents acute myocardial infarction. The next interval is the RR interval, or the PP interval. So this is the time between the 2 QRS complexes or 2 P waves. And this represents the beat-to-beat heart rate. And this interval, either interval, can be easily used to calculate the actual heart rate as well. And I'll show you what I mean. So hopefully you already know, one small box on an ECG represents roughly 0.04 seconds or 40 milliseconds. And one large box represents 0.2 seconds or 200 milliseconds. As you can see here in this rhythm strip, you have 5 large boxes between the R waves. So therefore, the RR interval is 5 large squares, and 5 large squares would then represent 1 second. So therefore, this patient's ECG, the heart rate, will be 60 beats per minute. So you can see in this table down here, if the RR interval is 1 large box, then it would equate to a rate of 300 beats per minute. And then 2 big boxes, 150 beats per minute. 3 big boxes of 100 beats per minute, and so on and so on. And the easiest way to calculate the heart rate in a simple way is you count the amount of large squares and then you divide it by 300. So for example, yeah, there's the pattern. So if there's 5 large boxes for the RR interval, then it will then be 300 divided by 5, which is 60 beats per minute. So we'll go on to 2 descriptive terms for ECGs. So you have the first term, bradycardia. So this is a description that the rhythm is a slow and sustained rhythm, and it's defined as a heart rate below 60 beats per minute. And then you have the term tachycardia, and then this is a fast and sustained rhythm, and defined as any heart rate above 100 beats per minute. So these are 2 examples. So the top example is an example of bradycardia. And then just to show you the simple method I talked about before, there's roughly 9 big boxes, just a little bit more, for the RR interval. So if we then plug it into the equation, then you have 300 divided by 9, so then that's roughly 33 beats per minute, and this would be an example of bradycardia. And then the bottom example here, you've got another rhythm strip. The RR interval is roughly 2 big boxes, and therefore you plug into the equation again, 300 divided by 2, and then the heart rate for this patient would be 150 beats per minute, and that would be a tachycardic ECG or rhythm. Now I will go through a systematic approach to basic ECG interpretation. Just to note, this is a basic ECG interpretation. For more advanced interpretations, there's a few more other steps that we use. I won't be going into that much detail in this tutorial. So the first step we use is descriptive analysis. So that is basically you're trying to describe what you see on the ECG instead of trying to interpret it straight away. You have to describe what you see, and then after you've described what you see on the ECG, then you have to then look at the clinical picture and try to correlate the ECG to the clinical picture of the patient. So we'll start by looking through the steps of descriptive analysis. So first step I generally look at is the rate. So what we were speaking about before, to calculate the heart rate. So you can use the RR interval, which is the ventricular rate, and then you can also use the PP interval, which is the atrial rate. If they are in sinus rhythm or irregular rhythm, usually they can be the same, but in some circumstances, such as complete heart block or second degree heart block, the RR interval and PP interval may not be the same. Next step we look at is the rhythm. So is the rhythm regular or irregular? And we also try to see if there's a P wave for every QRS complex. And some things we can use to describe rhythm is whether it's in sinus rhythm, whether it's a supraventricular rhythm, a ventricular rhythm, or a junctional rhythm, so coming from the AV node. And then we will calculate some intervals. So what we talked about, the PR interval, and then the QRS interval or duration. And these can either be short, they can either be normal or prolonged. And then we'll look at any signs of infarction or ischemia. So this is looking at the ST segments, and then they can either have a normal ST segment or ST elevation or ST depression. And then last of all, we then tie this all together, and then we look at the clinical picture, and then we try to see if there's any clinical correlation to the ECG and our description of it. So I'll go through 3 ECG examples, and then I'll go through how I would interpret them in a systematic approach. So this first ECG is a rhythm strip. It's an 18-year-old male, and he's just having a cardiac assessment for sport participation. He's never had any symptoms or any cardiac history. So in this example, we'll go through the different steps. So first off, we go through the rate. So we can see that it's a regular rhythm. So we can just use the RR interval. And roughly it's about 5 big boxes, as you can see. And then we use the equation 300 divided by 5. So then this patient's heart rate would be roughly about 60 beats per minute. And then we'll look at the rhythm. So the rhythm is regular. And there's a P wave, which is the red arrow, for each QRS complex, which is the blue arrow. So it seems like it's a sinus rhythm. Then we look at any intervals. So there's a normal PI interval because the PI interval is less than 1 big box or less than 200 milliseconds. And then we look at the QRS duration, that's normal as well. That's less than 3 small boxes or 120 milliseconds. And then we'll go and see if there's any signs of ischemia or infarction. And then you can see that here, if you draw the isoelectric line there, it doesn't seem like there's any significant elevation or depression. So this is a normal ST segment. So then since everything is normal and it's coming from the sinus node, this ECG interpretation to start off with is sinus rhythm at 60 beats per minute. So this is a second example. So this is a 55-year-old female complaining of shortness of breath and palpitations. As you can see straight away, before any steps in the interpretation, the rate's irregular and not as regular as the one before, but we still need to go through the different steps so we don't miss anything. So what is the rate? So as you can see, there's a varying RR interval, and what you want to do is try to find the longest RR interval and the shortest RR interval, and then you calculate what the rates are. So you can see here, you have this RR interval is roughly about 3 big boxes. So then that would be about 100 beats per minute. And then this is the longest RR interval, which is roughly about 6 big boxes, and that would be about 50 beats per minute. So there's a varying RR interval, and then the heart rate is roughly between 50 and 100 beats per minute. The rhythm is irregular, and we can see that there's no identifiable P waves. There's no obvious P waves before each QRS complex at all. For the intervals, we're unable to calculate a PI interval because there's no P waves. The QRS duration is normal, it's not wide, and because it's less than 3 small boxes. And for the ST segments, there's no ST elevation or ST depression in any of the QRS of the ST segments. And all these key features of an irregular rhythm, no identifiable P waves, is very typical of atrial fibrillation. So this is an example of an atrial fibrillation ECG, and with a rate of between 50 and 100 beats per minute, which can be important because you want to see if they have a very rapid ventricular rate, anything above 120 beats per minute. So this is the third example, ECG example. This patient is a 40-year-old female with a history of dizziness. As you can see, this is not a rhythm strip. This is a 12-lead ECG. So you can see that the rhythm is more regular than the one before, but we still, like I said, need to go through the steps. What is the rate? So usually we look at lead 2 because that usually gives us the most clear P waves, and we can usually see the KRS complexes there. So the RR interval is roughly 5.5 big boxes. And then you can plug that into the equation, 300 divided by 5.5, so roughly about 55 beats per minute. The rhythm is regular, and there's a P wave for each QRS complex. In this example, when we measure the PI interval, it's roughly 8 small boxes. Okay, so 8. And each small box represents 0.04 seconds. So therefore, it's roughly about 0.320 seconds or 320 milliseconds. So this is a prolonged PR interval. And then the QRS duration, although there's a bit of a notch here, a little bit wide, but it's still less than 3 small boxes. So the QRS duration is normal. And then we look at any signs of infarction and ischemia. And then as you can see, there's no ST elevation in any of the leads. There's no significant ST elevation or depression. Therefore, there's normal ST segment. And then a prolonged PR interval is typical of a first-degree heart block if there are no drop beats. And this is due to a conduction delay within the AV node. So the ECG interpretation for this patient is sinus bradycardia because less than 60 beats per minute with first-degree AV or heart block. So in conclusion, proper ECG electrode placement is needed for accurate ECG interpretation, and that's very important. So we all should know where the landmarks are, and we have to palpate for where the intercostal space is to ensure we have an accurate ECG. It's important to remember key features of an ECG and so it can help you recognize normal and abnormal ECGs. And we should all be using a systematic approach for interpretation so that we don't miss any subtle abnormalities in the ECG. So I've asked Paul to give all of you some overnight homework, and there's just 8 ECGs for you to interpret. Try your best. I'll go through the answers tomorrow. If you haven't listened to or gone through Dr. Eshu's lecture, I suggest you do, and then you'll have more of a detailed look at the different types of abnormalities that can happen in an ECG. And that's it. Thank you for listening. Is there's any questions? Let me just open the chat here. Don't know how to open the chat. Chat. I'll just stop sharing the screen. Oh, okay. If there are any questions, you can type it into chat now, and I'll try to answer any questions there is.
Kenny, just while people might be asking questions, I just noticed that there were a couple of people waiting, and my apologies. We're still getting used to the technology. All of this has been recorded. So if you missed the last half an hour, you won't miss it. As soon as we're finished here, I'll post it on the views site. So my apologies if you've been waiting for some time. Zach and others, excuse me, please. It'll be posted very shortly, so you'll be able to see everything Kenny has gone over. As Kenny mentioned, there's homework, so it will be posted as well today. And the idea is that if you're yet to watch, or rather listen to the lecture, which was made available via Views this morning, and see the accompanying slides, I encourage you to do so. Perhaps watch this tutorial again, and then the questions, the homework that's been assigned, which will be available shortly, we'll go through that tomorrow. We'll get Kenny to answer all the questions, go through things slowly. As Kenny mentioned from the start, this is really important. At times, we as sonographers get a little bit caught up in the imaging and the mechanics, but the mechanics aren't possible without the electrophysiology sort of stimulating all the mechanical activity. So it's really important that you're familiar with, certainly with the basics, and Kenny's gone through everything in a very systematic and good way. I can see one chat question. Yes, so just to answer a question there, the physics lecture from yesterday has been posted, so that's already available, and this one will be very shortly. Everything we're conducting this week, you'll be able to access quickly afterwards. So I can't see any other questions for the moment, but as I mentioned, Kenny will be ready to go through the homework he's assigned for you tomorrow. I'll post it very shortly. In about 30 minutes time, I'll give a brief information session. I'm sorry for the delay in between. I just want to make it possible for everyone to be there. So there are no questions at the moment. I might sign out. And hopefully I'll see you all in about 30 minutes. Kenny, thank you for going through that so clearly and carefully, and look forward to hearing more from you tomorrow. So everyone, will see you again shortly. Thank you.